Thanks to the organizers for inviting me. Man, after listening to Mike and Rishi, I don't know whether I'm looking at the black box or standing in the middle of it. It's pretty scary stuff, but I am going to bring us back down to a little bit closer to earth and talk about continuous quality improvement. And I have just three things that I want you to think about that I think are important as we move forward in this area. The first is the need for accurate de-identified data capture from the EHR directly onto databases that we would be using for quality improvement or research, clinical research for that matter. Second, describe how computerized decision support tools, protocol lead to replicable clinical actions. And if this sounds like Alan Morris, you'll see a lot of that. And then lastly, just one demonstration. This is way on the bottom level of what Rishi and Mike were talking about, but show that this can facilitate early detection of patient deviation from their trajectory. And I think that's how critical care is going to change, is that we will know a trajectory for illnesses based on initial severity and other things, and we need to monitor that trajectory. And when people get off of that trajectory, you better pay attention. So, the factors that affect outcomes from critical illness are shown here. There may be others. Illness severity, PRISM started here with the VPI, very important for quality improvement. Organ dysfunction, chronic conditions, the individual that Jennifer spoke about, certainly social determinants of life, but the last one on there, how we deliver our critical care. There's huge heterogeneity in that factor, and that's what I want to talk about, because that is much of what quality improvement is about. So our practice are these complex patients, complex therapy, in an environment where people are getting stressed out, they're leaving their job after all this investment. The oncologists are now injecting CAR T cells into brain tumors inside our heads. That doesn't sound like a good idea. And so we're taking care of these patients. And of course, critical care medicine is life-saving. It's fun. You feel good at the end of the day sometimes, but it's also a dangerous place to be. And if you're a patient or you're taking care of patients, really, you want to get that patient the hell out of there as soon as you can do it safely. So, as an example of this, mechanical ventilation is the most common, I would say, life-saving tool that we utilize in the unit. All kinds of reasons for that. And certainly, it is life-saving. But at the same time, it is associated with every adverse event that you can think of, including risk for mortality, delirium, extra blood tests, anemia even. So again, it's life-saving, but if you don't need to be on the ventilator anymore, you need to be weaned and you need to have the endotracheal tube taken out. So this is where quality improvement may come into addressing all of this continuous advancement of care. And what I mean by that, instead of kind of a stuttered approach to how we change what we're doing, we need to think about doing it continuously. And one of the things about ICU liberation is it challenges you to assess patients regularly and make changes if they're appropriate. So here's the bundle of things. There's 6 of them, starting with always prioritize the treatment of pain. B is about weaning the sedation, weaning the mechanical ventilator. And we in pediatrics look at that quite differently than the adults do. And that's really the focus of what I'm going to talk about as an example of a quality improvement trial around this. The drugs that we use, minimizing delirium, because it in itself is associated with everything bad that you can think of. Getting the patients mobilized, SAPNA, we'll talk about that, I bet, and then engaging and empowering the family in the care plan. So, some facts about ICU liberation. It's an additional holistic approach to patient care that, in addition to focusing on organ dysfunction and resolving that, that's basically what critical care is. It looks at other things that are related to treatment of symptoms. It can be, utilized in any setting from the beginning of the ICU admission. Importantly, it is a bundled approach. There's 6 elements, and they are so integrated with each other that the effect together is more than the sum of the parts. At least some people believe that. There's other examples of that, the CLABSI initiative, the Surviving Sepsis campaign bundles, for example. The last one here is the most important. It's easier to talk about this in adults than kids, but it's still true. If you can get a patient that's more awake, more engaged with the care plan, that is a good thing. And that is a big goal of ICU liberation. So why am I even harping about this? I don't know how many of you know about this, but there are 2 big adult studies looking at ICU liberation. And this is the kablamo slide for me anyway. If you look at these are all hazard ratios of getting out of the ICU alive, getting out of the hospital alive, and overall decreased risk of death. Look at these hazard ratios. There is nothing that we have ever done in research that has any chance of being even close to these hazard effects. And what's shown here is the proportion of bundle elements that are performed in relation to these decreased risk for mortality. These are huge effect size, and I really think we should be practicing critical care as utilizing this model, at least one aspect of it. So there's these big outcome measures: decreased risk of death, fewer days of mechanical ventilation, less time in coma, less time in delirium, less physical restraint use. Now, we're talking about kids now, not adults, maybe different. You can't sit down and have a reasonable conversation with a 3-year-old about that. But when the adults were discharged from the hospital, they had a greater chance of going home rather than to a nursing home. And they had less chance of getting readmitted back to the ICU. So for each of these, there was a nice, convincing dose-response relationship between the proportion of bundle elements performed and each of these outcome measures. Actually, there was an initial PICU collaborative in this as well. Very disorganized, would benefit from everything we're talking about today. And it also found a significant decrease in mortality, but it just doesn't quite make sense because it's not linked to other things like decreased ventilator days or decreased incidence of delirium. So I'm not exactly sure why the disconnect with those various signals, but there's an opportunity to study it again, and that is the context in which I'm going to talk about quality improvement. And this is a trial that's sort of getting bantered around now because there may be a good amount of PCORI money to support it. It is the approaches to performance of PICU liberation elements, and I would say it's basically fashioned after Mike Bell's ADAPT trial. a comparative effectiveness non-RCT trial that just looked at best practice for treatment of traumatic brain injury. So, pragmatic, prospective, comparative effectiveness, watching how people do things, observational cohort study that endeavors to identify best practice of performance of ICU liberation elements around B, weaning sedation, weaning mechanical ventilation among critically ill children requiring invasive mechanical ventilation. So this is the traditional quality improvement, the PDSA cycle. I'm going to talk about each of these as it might relate to constructive, this particular study I'm talking about and beyond. So framed a little bit differently, designing this study, this prospective descriptive cohort study. Second, if doing this and watching how people operate around ICU liberation elements is not enough, we could introduce evidence-based practice as we have it today and ask the question, why aren't you doing this? The third is studying it, the same variables, which I'm going to talk about shortly, utilizing clinically meaningful patient-centered outcomes. For me, this is a big deal in quality improvement. If you're going to do the study, use outcomes that actually are important. And there's been references to that at least twice already today. And then the last phase is ACT or tweaking the system with another cycle, PDSA cycle. How do you disseminate when you identify a good practice? How do you sustain it locally, particularly? Very hard to do. And then lastly, this idea, instead of acting reactively, is there a way to do quality improvement proactively by anticipating, based on what's going on, what the trajectory of this patient is going to be, and we've already heard a little bit about that as well. So here is the plan for this descriptive cohort study. It will involve ICUs that are interested in quality improvement and that are interested in this model of PICU liberation. This ICU liberation is already embedded into Cerner and Epic, and it can be turned on. I'm not quite sure that it's really valuable because it's more of a checklist than really a data collection tool for an interventional or for an observational trial. Working on the database, we're just talking about that, what the right elements are. Each site will have to kind of assess what their practice is around the elements of ICU liberation, especially the B element, the ventilator, and sedation weaning. And that could be variable. It probably is even among the docs there. Talked about heterogeneity. In this instance, it would be good to have a nice heterogeneous approach. And I frankly don't know what the spectrum of practice is going to be. If it's very different between sites, that would be ideal, because then you have a chance of identifying best practice. If everybody's sort of practicing the same and it's kind of vanilla, then you probably have to add some kind of an intervention on top of that and then see what happens. So here's my first bing, bing, bing. This is what I think is important. There needs to be accurate data capture from the EHR directly down to a database. And this is important for this trial, and I think it's a tipping point for clinical research in general. We have to quit using research coordinators to take data from here, maybe put it on a piece of paper even, and then put it into a database. It is entirely inefficient. These research coordinators should be doing quality of life surveys or interacting with the families, but not doing this mindless data transformation. I've got fires wrong here, but there are tools to do this now, and I'm not saying I know the right one because I am basically illiterate on this whole subject matter, but have been working with people at Johns Hopkins with this thing called the EDGE tool. And you may or may not know this. I didn't know any of this until a short time ago. Data at many places, I think most academic centers, is now in this form as suggested by this consortium of people. Utilize with this in place, the data can be aggregated, analyzed, and harmonized from other sources, and institutions can build this OMAP data model, and then they can load the relevant transform data into it. This process right there, extraction, transformation, loading, ELT. And this EDGE tool is just a package of software tools that facilitates doing this. And the people at Johns Hopkins, especially the neonatal intensive care unit people, have had great success in doing comparative effectiveness research with this tool. So I may get some other ideas from all of you. It is said that this can be implemented into Seattle Children's Hospital with about 50 hours of IT time. And if each site, is that unrealistic? I'll be glad to know. That's what I was told. And there's lots of data quality checks with this. So I am just sort of telling you what I know about this, but I think something like this has to occur. We have to do clinical research differently and have to have a valid way of collecting the data that we want to use consistently, have it available for quality check, et cetera. So one part of this grant would be to have the money to be able to install this, if local IT people would even do it. But I think this is the way we need to go. And whether it's virtual PICU, Randall, or something, I don't know. But I think this type of an approach is exactly what has to happen. It would be nice if we could do it with this study, and PCORI may have the money to do it. Many sites who actually would agree to do this would be very powerful going forward. And Mike Dean may have some comments about this too, because I think there was interest in this kind of approach in Capcorn several years ago. So here's just this EDGE tool in the library of this different software. You probably can't read it. Don't ask me to explain any of it because I don't know what it means. But basically, it sounds like something that has worked and it could be exportable to other institutions as well. So a good topic for discussion. I would like to learn more. So getting back to this study, here are the specific aims right now as they sit. Identify the best practices for weaning sedation and mechanical ventilation associated with the shortest duration of mechanical ventilation adjusted for illness severity. The second one, the same, the effect on, or the best practice for avoiding delirium, again, adjusted for initial illness severity. And the third, same thing, best practices for weaning sedation, weaning the ventilator, that's associated with the least deterioration from baseline measured at 1 month, functional status and quality of life. This is for PCORI. This is exactly what we'd like to do, is wean the ventilator as expeditiously but safely as possible. So these are the three specific aims as they stand right now. The doing part of this, if there is an intervention that is needed, are twofold, and everyone in the room knows about these. Martha already referred to them as well. We have guidelines for sedation, analgesia, neuromuscular blockade, and we have guidelines for the ventilator and suggestions for weaning and what might constitute a safety check so it's safe to do an extubation readiness trial, for example. So the question ultimately would be, here are a lot of smart people who spent thousands of work hours going through the existing literature, and there still is a lot of lack of best evidence, but these are people who have thought about it. These are the suggestions about how to do it. Why aren't we doing this? So the actual study, in terms of clinically meaningful outcomes, Martha and others have referred to this. We talked about this a long time ago, but right before we did the SHIPS trial, we did a survey in 4 ICUs, 2 in the United States, 2 in Canada, and we asked the healthcare professionals here in the red bars and families in the ICU at that time for a hypothetical ICU interventional trial. What would you think is most personally important to you, your child, your family? And we asked both parents and healthcare providers, and not surprisingly to me is after survival, both groups chose quality of life and functional status. And we didn't have these prioritized in any way. These were sort of jumbled up. The second one did surprise me. I always have thought that our focus on organ dysfunction is maybe a little bit more than we should be, but not so. I guess the parents at the bedside, the caretakers at the bedside are watching this disease process, organ dysfunction, get worse, get better. So this is very important, and this APPLE trial would focus on the ventilator and pulmonary failure. Also important, PICU duration of stay, hospital duration of stay, and then other things. But how the kid turns out after they've been critically ill is important for everyone, not surprising. So here is this study, at least as I conceive it now. The first focus is on sedation, administration, and weaning. Specifically, every time that nurse does a sedation assessment, a RASS score, how many of those assessments, and there's like, these happen what, every 2 hours on average? I don't know, I think so. What proportion of those are associated with a wean of sedation? Pick a number, within 30 minutes, an hour, whatever. Similarly, for the respiratory therapist looking at the ventilator, and I think on average this happens every 4 hours in most units, for each of those ventilator assessments, what proportion of those are associated with weaning some aspect of that mechanical ventilation? As you know, these two things are linked together. One affects the other. But the outcome then is this idea of how long does it take to get to a extubation, readiness testing, safety checklist clearance. That is, when is it safe to do an ERT? And the hypothesis is that as the proportion of these sedation and mechanical ventilator weaning assessments increase, the duration of time to that first safety checklist pass will decrease. And then in turn, the other important aspect is eventually we want to do that extubation readiness testing and get to a trial of extubation, but maybe as assessed every 12 hours or once a day. How many of these checklists, it's okay guys, happen before the first extubation readiness testing actually occurs? So with all of this, the outcome measures are days on the ventilator, ICU days. Those are almost linear related for most patients. Delirium, change in functional status and quality of life, and mortality. So you can see that it would be nice if the computer could pull out the detail from the EHR that's required to do this. The extubation safety checklist, is FiO2 less than 40%, is the P less than, pick a number, 8. There are suggestions on what this checklist is. And when the light turns green, do people act and actually follow through? So the last part of the PDSA cycle is this ACT, and now I'm going to get a little freer with my comments here, but acting is, getting ready for the next PDSA cycle. What did you learn? What can you tweak? How can you disseminate it? What are actions that can be suggested to hospitals to change their practice? What is the generalizability? And then lastly, this idea of instead of reacting, proactively anticipate how things are going to change. And I'll start this with, this is just very distasteful for most people, for lots of people. This idea that standardization is the foundation for iterative improvement. Let me be a doctor, I train how to do this, whatever. But if you don't standardize, if you don't start with something, you will never be able to measure improvement because there's too much noise in the system. This is true for research, figured that out a long time ago. It's also true for quality improvement, and it's the cornerstone of the Toyota way. So just get over it. So, standardization facilitates all kinds of things that are useful for doing quality improvement as well as clinical research. I'm not going to discuss these in any detail. But then what is the ideal state? Now we're at ACT, and what's going to happen next? And Alan Morris would say the right decision or the right action the first time and every single time. So how do you get to nirvana? Well, this is the pyramid right here. This is the individual doc knowing that how they practice is the best way to do it. There are local protocols, algorithms, pathways that now increasingly are based on national guidelines. And I would say this is our practice right now. This is basically what we do. And we need to move on and get to this the other side of how we might practice. And this is using these tools that people smarter than me are talking about today. But this, the open loop, the closed loop thing, I'll show you a couple examples of that, but computerized decision support, open loop, here's the situation, the computer makes a suggestion and the clinician can follow it or not. Kit Newth and Robbie have been working on this for decades. I think if people were less afraid of letting go of their ego and letting the respiratory therapist act at the top of their practice, utilizing this extra decision-making power, we could facilitate, for example, weaning from the ventilator faster. So protocols now have been shown, protocols. This could be on paper, this could be on a computer, but in general, this idea of doing things the same way have been identified as good for things like weaning the ventilator, administering transfusions, sepsis resuscitation, glycemic control, and even sedation and analgesia. And it is useful because it avoids errors of omission. It absolutely improves efficiency because a good protocol includes an element of time, then it's called clinical standard work. And what I mean by that is instead of the ventilator may get weaned on rounds, and maybe when it's less busy in the afternoon, somebody will come and wean it again. Maybe the night team will or won't. A computerized protocol that includes time, clinical standard work, asks the question like every 4 hours. This is the situation. It's safe to wean. Are you going to do it or not? It would decrease costs because of efficiency and maintain standard of care. This is a quote directly from Dr. Morris. Computer protocols, computerized decision support, or e-actions, as he likes to call them, lead to replicable clinical actions. This could lead or reduce this mindless, unwarranted variation in our practice of critical care medicine. This is a paper that was just recently published. Here's Chris here as second author. He may be talking more about this later. But the basic idea is the computerized decision support, along with what the clinician is capable of doing, will be better than just the clinician alone. This is not just about cognitive load. I'm busy. I have 17 patients today that I need to write notes on. This is also about the fact that a kid just came in with sepsis and his feet and his hands are black and we can't find the right drugs to keep us, and the whole unit is pulled over in that direction. And the rest of the unit, they don't get weaned. They don't get the care pushed like ideally it would be. It also is the young nurse, the young respiratory therapist, who are receiving all their orders from the doc. They're too young, they're too inexperienced, and they're afraid they're going to get yelled at if they make a mistake. So people need to be allowed to practice at the top of their ability, not be micromanaged by a physician for every single change that needs to happen. Okay, so here are just some additional quotes from Dr. Morris's first paper that he wrote on this subject, just sort of emphasizing that these computerized decision support tools can be built into the EHR, and then we might actually have a tool that, instead of increasing our work, could actually be helpful in our daily work, and also progress this patient along in a regular fashion to get them out of the ICU as soon as it is safe to do that. So these computerized decision support tools, or e-actions, enhance the nuances of everyday clinical decision making, informed by all kinds of things that can be built into the model, now even including unstructured data from, for example, written progress notes. So just as an example, this is from a while ago, one of the early trials of computerized decision support for mechanical ventilation. These are adult patients, and I picked out one trial to show you that it's possible. I'm not saying that this is a general effect, but this was very significant in terms of reducing days on the ventilator for adults. And actually, this has been studied with a systematic review and meta-analysis in kids. The total number is only a little over 300. There was one trial that enrolled 260 children, and with a computerized protocol, they actually reduced the duration of mechanical ventilation by a day and a half. The two smaller trials didn't show that effect, but they did show that there was a shorter duration of weaning the ventilator. So there is already some existing evidence that this approach works for children as well as adults. Here's another example. This is glycemic control, utilizing like 3 different approaches. One is a simple guideline that you might have in your unit. The next in red is the protocol at the bedside for the nurse and or physician to refer to, and the third is a computerized decision support tool. And what you see here are 2 things moving right to left, is that there are more values in the target range in gray, and the distribution is tighter. So it's both exactly where you want to go. And then if you get people to actually accept this and say, okay, yeah, I agree, this can actually work, you can disseminate this tool and not just use it in one place, but at different places, including international implementation. So these decision support tools, this is actually closed loop. The mechanical ventilation was open loop, but they can work. And certainly they deserve more attention because they can be tweaked to work better. And then lastly here, just a little bit about our artificial intelligence. I ran across this article a while ago that looked at keeping track of where the patient is going, where they are, utilizing both structured and unstructured data. So the usual variables plus this text that we add in terms of interpreting all of that data to this input in terms of predicting sepsis. So what you see here is the area under the curve for this computerized prediction algorithm when tested 48 hours in red. The next one is black, 24 hours before the actual event, 12, 6, and 4 hours. And the first thing is the area under the curve here is like 0.9 or better for all of these. So that's pretty darn good in terms of specificity and sensitivity. The black dots are the modified early warning score, SIR score, SOFA, QSOFA, scored at 4 hours before the event. So this tool that these guys developed, and there's multiple examples of this, Vinay, you would know that this is also being looked at for predicting cardiac arrest, so you can prevent it instead of respond to it. This, for some HEMONC patients at the Mayo Clinic, they are looking at the trajectory of their patients and actually use systems somewhat like this, not as sophisticated as they might be in the future. But here's my last point. With AI, we should be able to detect early patient deviation from their expected trajectory. And I believe in the future, every patient that comes into the ICU will have an expected trajectory. For DKA, when they come into Seattle Children's Hospital, they're going to spend 0.8 days in the ICU. That's when their BOB is going to correct to less than 1, and then they're going to get transitioned and go to the floor. We can do that with other diseases likely too, with help, with more data. Okay, so everybody knows Karen Chung, I think, a pretty well-respected lady. This is what she said, I believe it. PICU liberation is the poster child for quality improvement and quality of life improvement. So I leave you with these thoughts. I believe that the reason why ICU liberation works is because it emphasizes weaning. And why is that important? Waiting is the biggest waste in medicine. Waiting for the consultation, waiting for the Christmas holiday to be over, et cetera, et cetera. Waiting is the biggest waste in medicine. ICU liberation promotes this idea of not waiting, but continuously advancing care, weaning the sedation, mechanical ventilation, avoiding delirium, all these things continuously. So wean the sedation when it's appropriate, wean the ventilator when it's appropriate, and minimize this idea of just being completely immobile in bed. Do this with treating pain and engaging the family in the care plan as well. Data science, computerized decision support tools could facilitate all of this remarkably in the future, and proactive scheduled assessment and weaning will reduce this waste of waiting, and it will improve the value of the care that we deliver in the ICU. So thank you for your attention. Thanks for the invitation, and I look forward to discussion later.